Hey guys, so in this lecture we are going to be talking about vital signs. You should have already watched the vital signs lecture, and that's where I'm standing at the whiteboard going over heart rate, respirations, and things like that. Today we're just going to touch a little bit on the oxygen chapter, so the oxygen needs in respiratory therapies chapter, and we're just going to talk about a few key terms and things there, and then we're also going to cover some specimens. We're going to talk a little bit about specimens and what I need you guys to know about that. So first thing that we're going to talk about, and if you guys want to go with me in your book, this should be chapter 27, but if you have one of the older books, you're going to be in chapter 26. It's labeled Oxygen Needs in Respiratory Therapies, and we're just going to be looking at some key terms there. So the basic one that I want you to learn here is oxygen concentration. You will mostly hear this referred to as oxygen saturation. So oxygen concentration, oxygen saturation, same thing. You will mostly see it charted as O2 sat. So 0.2 oxygen, sat, S-A-T, as in saturation. So oxygen saturation. The definition here is the percent of hemoglobin containing oxygen. So this is something we cannot check manually. We are checking this every time we're checking our patient's heart rate with a pulse ox. And this is a very important one. So when we are charting, every time that we get vitals, when we chart blood pressure, heart rate, respirations, temp, we are also charting an O2 sat. So a normal oxygen saturation, and we're getting this with the pulse oximeter, and a normal oxygen saturation is between 90 to 100%. It's measured in percentages. We want that above 95. So above 95 is our goal. That doesn't happen for all of our patients, but we want it above 95. We are not concerned until it goes below 90. So 90 to 100% is our normal. If I have a patient, nursing home or hospital, and I go in to check their vital signs and their oxygen is reading 88, 89, even 87, so I'm lower than I need to be, but I'm not at an emergent level. Okay, we're not in the 70s where I'm afraid that this patient is getting ready to, whatever's going on with them. So it's 87, 88. First thing that I'm going to do, if my patient is lying down, if they are in bed lying down, I'm going to sit their head up. Okay, so I'm immediately sitting them into a Fowler's position. And just sitting in this position normally will raise that oxygen saturation up to what I need it to be. If this patient has just sat down, even if they just walk to the bathroom and back, a lot of times that will be enough to lower their oxygen concentration down to 87, 88. So I'm just going to give them a minute, make sure they are sitting straight up in that Fowler's position. If their oxygen is still not going up, if they're still reading 88, 89, my next step is going to be to put a nasal cannula on them. So I'm going to deliver oxygen with a nasal cannula. A nasal cannula is what we mostly see patients receiving oxygen through, and it's just the tubing that goes in their nose. If they have that concentrator in their room, or if we're in a hospital and they have the tubing from the wall. Okay, so if you see a big oxygen tank, if you see the big oxygen concentrator sitting on the floor, or if you see the tubing in the wall, if they have oxygen in their room, then they have the order. So you do not ever need to ask a nurse. If you would have a question, ask the nurse or notify the nurse. That's never going to be the answer. If they have oxygen, then you as the nursing assistant can put that on them. Okay, so first step, if their O2 sat, if their oxygen saturation or concentration is below 90, is to sit them up in Fowler's position. After that, if it doesn't go up, now I'm going to apply oxygen. Okay, so I'm going to apply O2 or oxygen via the nasal cannula. Okay, and we're usually running that at 2 liters a minute. Okay, so O2 at 2 liters a minute. The next few terms that I want you guys to know here, and again, these are right in your guys' book. It's just the very first page, key terms. If you want to follow along, you should have already listened and read about bradypnea, tachypnea, and those things, slow respirations, versus fast respirations. Apnea is another important term, and that is just the lack of respirations. So like sleep apnea, patients who have sleep apnea, they have a lack of respirations, so they have periods of not breathing in their sleep. Okay, so apnea is another term that we need to know. Dyspnea is one that you guys, I'm sure, have heard at this point. Dyspnea is difficulty breathing. Okay, anytime I have that pnea, that is going to be breathing. Dys is always difficult. So dyspnea, difficulty breathing. Another term that I would like for you guys to know is cyanosis, or you may hear a patient being referred to as cyanotic. So when we're talking about somebody showing cyanosis, that is just the blue color, and it normally will appear around their mouth. On their nail beds will start to look like a dusty light blue color. That's from a lack of oxygen. So that's cyanosis. And then orthopnea, this is a very common one with our geriatric patients. You will often see patients that will sleep sitting up, so they'll sleep in that Fowler's position. Oftentimes they will sleep in a recliner, so they're patients that will just live their life in a wheelchair and a recliner, and that is because they have orthopnea, which means they have difficulty breathing when lying down. So they feel like they are suffocating when they are laying flat, and then they feel like they can breathe normally whenever they're sat back up. So that's orthopnea. And then Cheyenne-Stokes respirations. This is another important one, and this is very common in our dying patients. So if I have an actively dying patient, this is something that I would need to make sure that I am educating their family on. It's important that you guys understand what you're looking at when you have a dying patient that is displaying this type of breathing. This is Cheyenne-Stokes respirations, and that term is right there in the book for you guys. But essentially what happens is I have a patient who is going through phases of tachypnea, so super fast respirations, followed by periods of apnea. So they're breathing very fast and heavy, and then the breathing stops. And then after that period of apnea, they will begin to have some bradypnea, so just very slow breathing, and then followed by another period of apnea. So what happens is we have families sitting at their bedside. You have a dying patient. They're breathing very heavy and rapidly, and all of a sudden their breathing stops. The family assumes that they've passed. So it can be very scary. It's scary for aides and nurses if they don't know to expect this. So Cheyenne-Stokes is a very important term for you guys to be familiar with. We'll talk more about those when we do our full review, our full state review, but for now, understanding oxygen saturation and those few terms is all I need from you guys. The other thing that I want to talk about with you, just briefly, is specimens. There's a few different specimens that we're going to go over. Obviously, urine specimens are going to be the biggest one. UTIs are very common in our geriatric population, so we're getting a lot of urine specimens. When I am getting a midstream specimen from a patient or a clean catch, very important that I'm making sure that my patient is cleaned before I begin before I get that specimen from them. So usually all of the specimen cups will come with a towelette that I can use to just wipe my patient off, or give them to wipe themselves off. Then if I'm doing a midstream specimen, that's exactly how it sounds. I want my patient to begin urinating, and after the flow is began, I will put the cup underneath the stream, and then before that stream is done, while they're still urinating, I'm going to remove the cup. Okay, and that's a midstream specimen. Anytime that I am collecting a specimen from a patient, whether it's urine, stool, or sputum, either way, doesn't matter. We're never doing sterile specimens because none of these body fluids are sterile. So we're always doing clean technique. We want this to be as clean as possible. So when I have my specimen container here, I can touch anything on the outside. When I take this lid off of the container, I'm always sitting it can't see that, but I'm sitting it up. Okay, so I don't ever want to touch inside of this lid, and I don't want to touch the opening. I'm only touching it down here on the top. And then same with the inside of the container. I can touch the outside of it. I don't want to ever touch inside of that to keep it as clean as possible. When I am collecting specimens, the most important thing is that I'm labeling them properly. So if I get a perfect specimen and it's exactly what the lab needs, and they want name, date of birth, and room number, and all I give them is the name and date of birth with no room number, they're going to chuck that specimen and ask for a new one. So it won't matter if I did everything else correctly. So labeling is the most important thing here. When I'm getting a urine specimen, I always want to fill that cup as far as I can. You can't have too much. You can certainly have too little. So just as much urine as I can get. Oftentimes, we can get a specimen with very little, like 5 milliliters of urine. But we want as much as we can. Now, when we are getting a stool specimen, we need to have at least 2 tablespoons of stool. So 2 tablespoons, and I'm using, normally we're going to have our patients go either in a hat or a bedpan. A hat is the most ideal, and that is just kind of a half moon shaped bedpan that sits on the back of the toilet. So that way, the way anatomy works is they should sit down and their urine will go into the toilet and the stool will be collected into that hat. The tricky part about stool specimens is that if any urine gets into that stool specimen, it is contaminated and we cannot use it. So urine can never touch a stool specimen, which makes them very tricky to get. So 2 tablespoons of stool. We're using a wooden tongue blade or a wooden spoon, either or, to collect it from the hat and put it into the cup. When we are getting a sputum specimen, it's important that we are getting that from the back of their throat, so we don't want just a little bit of spit that they have in their mouth. We want them to kind of, cough and then everything from the back of their throat come up. We do not want them to brush their teeth, use mouthwash, anything like that beforehand. If they have a dry mouth, they can rinse their mouth with water, but nothing else. So we need 2 tablespoons of stool. We need 2 teaspoons of sputum for a sputum specimen. And that is collected directly into the specimen cup whenever we're getting that. I think that's all. I think I'm going to end your guys' lecture here. I don't want this to be very long. When we come back in, we'll have kind of an overview. So at this point, if you guys are up to chapters 35, 36, you've completed everything except for 1 assignment. So you guys only have 1 assignment left when you come back. So there's 5 lectures that you should have watched at this point. So you guys, please make sure you've watched all the other videos. Reach out to me if you need anything, and I will see you. I don't know when I'm going to see you. I'm going to see you whatever your class day is. So be safe and warm and all that stuff. And I love you guys, and God loves you guys, and have a good day. Bye.